I just have to. All right, let's jump into this. And I realized, and I'm impressed that one of you was also studying it during the break, but I realized that that one question that we went over, that multiple choice question, bear with me here. This question. It said, and I've got to remember where that slide was approximately. It's not right there. Be a little lower. Be a little lower. Maybe a little lower. This one right here. The answer is actually E. It won't be on your exam, which will open up later tonight.
It was a smart book question, which is why I questioned
it. Was?
It was either that or in the extra credit. It was a question that I answered somewhere. And I knew it was not norepinephrine, but it's ADP, right?
Yeah. No, ADP. Yeah.
AD.
No.
No.
ANP. ANP.
Yeah, right.
atrial natriuretic peptide. What it does is it comes from the atria. When, let's see here, it increases the blood pressure. No, which of the following decreases it? When there's too much stretch in the right atria, it gets secreted. And what it does is it works on the kidneys, bringing down blood volume, decreasing the blood pressure. And are there any questions about that? It did make me smile when I got a text just a little while ago saying, well, I looked it up and that's not the answer. I'm like, I looked it up too and that's not the answer. You're right. Let's finish this out. So baroreceptor reflexes. Remember where these are located. So they're located in the carotid sinus, that dividing point of where, dividing point of the internal and external carotid arteries and the aortic arch. When the blood pressure gets elevated, they sense that change in stretch. And the result is that they increase in their rate of firing. They send that signal to the cardiovascular center in the medulla oblongata. And the medulla oblongata, as a result, decreases sympathetic nervous system activity, decreases sympathetic nerve constriction, and increases parasympathetic nerve activity to slow down the heart. I will let you know, and I don't think it ever comes up here, but the parasympathetic nervous system does not regulate the radii of vessels. Sympathetic alone does. So this is one of those few things that's not dually regulated by those two. So this is working when it says it's increasing the parasympathetic, it's increasing it to slow down the heart rate, has no effect on blood vessels. So let me type this up because this is kind of important. Because we like to think that the parasympathetic and the sympathetic are always combating effects, and they do for the most part. But in the blood vessels, the sympathetic nervous system is the only one that regulates, is the only part of the autonomic nervous system that regulates the diameter of vessels. So when it's increased firing, you get increased vasoconstriction. When you get reduced sympathetic nervous system, you get more vasodilation. When it's not firing at all, you get maximal dilation. Everything else that we talk about almost is dual regulated. This is the one of the few places where it's not. It's only the sympathetic nervous system involved. So when we're looking at this question, or this comment right here, what that's saying is that you're decreasing cardiac nerve activity. So, we know that the sympathetic and parasympathetic both work on the heart. So you're decreasing cardiac nerve activity. You're decreasing sympathetic vasoconstriction. So it's more vasodilation. And you're increasing the parasympathetic nervous activity on the heart, because the parasympathetic nervous system does not work on the blood vessels. I can tell you I made a really embarrassing moment for myself last semester, my first time teaching physiology at Stevenson, because I forgot that. And I kept thinking, well, why is this not making sense? And it was, of course, in the middle of class. And then I remembered that the sympathetic nervous system is the only one controlling resistance of the blood vessels with regards to the blood vessel radii or their diameters. So you increase heart rate, you decrease heart rate, decrease the stroke volume, because you're slowing down blood pressure, it's too high. And you're decreasing, you're increasing, no, you're decreasing vasodilation. I got myself confused. Go tell her. She came home. She's coming to get you, Mom. As a result, you decrease cardiac output and you decrease total peripheral resistance. Remember, if you decrease heart rate, you decrease stroke volume, you're going to decrease vasodilation. Or, let me say it differently. If you decrease heart rate and decrease stroke volume, you're decreasing cardiac output. If you're increasing arterial and venous vasodilation, or decreasing it, the result is that you're going to decrease the total peripheral resistance. And the result is that blood pressure is decreased overall. Are there questions about that? So this is the way that Biol reflexes are going to restore blood pressure. So increased firing is going to lead to a decrease. Increased firing is going to lead to an increase in, increased firing.
Bring it in. Bring it in. Bring it in. Bring it in. Bring it in.
Bear with me. I'll do it. Just a sec. Give me 1 second. I think they're no longer there. So increased blood pressure, those Biol receptors start to fire into the afferent nerves. It stimulates the cardiovascular center that decreases sympathetic activity on the heart, decreases sympathetic activity on the blood vessels, and increases parasympathetic activity on the heart. As a result, we get decreased heart rate, decreased stroke volume, and more vasodilation. And the result is that we decrease total peripheral resistance and we decrease cardiac output, bringing the blood pressure back towards normal. So baroreflexes are going to restore. When the blood pressure falls below normal, the carotid sinus sensors, the baroreceptors, stop firing. They go down significantly. And the result is that we get less firing of those nerves associated with those receptors. And we get less firing of the cardiovascular center. And the result is that you get increased sympathetic cardiac activity on the heart, increased sympathetic vasoconstriction, so more vasoconstriction, and decreased parasympathetic, so less slowdown of the heart. And the result is that you're going to increase stroke volume, increase heart rate, and increase vasoconstriction. It would help to have a little arrow right here that said this is going up too. I may have to put that in later, which I'll do. Increased cardiac, and that's going to result in increased cardiac output, because remember, cardiac output is a product of heart rate times stroke volume. Times total peripheral resistance. And therefore blood pressure is increased towards normal. Questions? Determinants of mean arterial pressure. Mean arterial pressure is, remember, it's determined by heart rate and stroke volume, so cardiac output, times the peripheral resistance. Therefore, mean arterial pressure is cardiac output.
Can you repeat that, Miss Mary?
Yeah. So mean arterial pressure is determined by the heart rate times the stroke volume and the peripheral times the total peripheral resistance. And since we know that heart rate times stroke volume equals cardiac output, then mean arterial pressure is heart rate times stroke volume times total peripheral resistance.
Okay. I wrote the wrong thing. Okay, got it. Thank you.
I understand. So looking at, if this is a scheme that's been drawn up showing how mean arterial pressure is affected by cardiac output and total peripheral resistance and how they're affected. So bear with me here. Cardiac output is affected by the heart rate times the stroke volume. The heart rate is affected by the sympathetic nervous system and the parasympathetic nervous system. The stroke volume is affected by preload, contract. Hey, Louie, I told you he's got a good bark. Louie, stop. Buddy, no. No. All right, you guys, let me introduce you to my dog now that I have another camera. Not that camera, this camera. I don't know if that didn't help. 1 second here. Okay, I've got a thing that, okay. Louie, you're gonna say hi. Louie, come here. Louie, buddy, you were supposed to come here. Come here, Louie. Do you see him?
Yeah, he's cute. He looks a little camera shy though.
He's shy because I was just getting after him for barking.
Yeah, there's
Louie, stick your head out. Louie, buddy, come here. Louie,
Hi,
come here.
Louie.
Mhm.
Come
Hi,
here.
Louie.
Has she been out?
No. Louie,
take-
Mom, I
Oh,
can't hold.
oh,
Louie,
come here, sit, sit,
sit, buddy.
sit, sit.
He's actually, I think he is a little camera shy because normally he's actually really good about sitting. We didn't train him.
He's so cute.
Isn't he
is
sweet?
He is sweet.
He's a lovable bug.
He's very handsome.
Yeah, he's something else. But we're falling in love with him really quite quickly, having only had him less than a week. So preload affected by venous return. Remember, this is how much blood comes back to the heart and drains into the heart before the heart contracts. So controlled by venous return, which is affected by the sympathetic nervous system through the blood vessels. Actually, no, wait, sympathetic nervous, yes, through the blood vessels also. The skeletal muscle and respiratory pumps. As you reduce the pressure in the chest, it draws the blood to the chest because blood is going to move toward from a higher pressure to a lower pressure. And blood volume, which is affected by antidiuretic hormone and aldosterone. Total peripheral resistance is affected by the blood vessel length, the blood viscosity or volume, which is affected by the antidiuretic hormone and aldosterone, and the blood cells. Remember, blood volume is going to be stimulated to increase by antidiuretic hormone and aldosterone. The vessel radius is most affected by angiotensin II, antidiuretic hormone, and the sympathetic nervous system. Are there any questions about this? What is the mean arterial pressure for a person with 10 millimeters of mercury and 65 millimeters of mercury as their systolic and diastolic pressure respectively? So remember, this is that mean arterial pressure equals the diastolic pressure plus 1/3 of the systolic pressure.
B.
E is in echo,
B is in Bravo.
B is in Bravo. I honestly haven't calculated it. Does that sound right? Well, Rachel, there's nobody saying it's not, so yes, it's right. Okay, here's an interesting question. It is hot outside. Person has a blood pressure of 108/67. Remember, average is 120/80. Their heart rate is 110. What is occurring and what would you recommend?
Well, I would say dehydration.
Why do you say dehydration?
Well, when you're dehydrated, it reduces your blood pressure. And
Because it's reducing your blood volume, right?
yeah, yeah.
Yep.
So I'd recommend that they go inside and have water, cool themselves down, drink some water, rehydrate.
Why is their heart rate going up?
because it's trying to pump more blood.
to maintain their cardiac output, right?
That's what I would assume. Yeah.
You're right. Do you understand how that, does everyone else understand how that works?
No.
Okay, so if I'm looking, I'm guessing just from looking at this, so their total peripheral resistance is down.
Mm-hmm.
And so if I'm looking at what we know is a regular blood pressures are 120 over 80. Bear with me here. I'm gonna come to the whiteboard. Rather than try to figure out their total peripheral resist, their mean arterial pressure, I'm gonna, trying to figure out how to calculate their total peripheral resistance. I'm looking at it this way. Bear with me just for a second here. So cardiac output equals stroke volume times heart rate. Times heart rate. Heart rate. Their pressure, blood pressure, is 108 over 67. Their heart rate equals 110. Cardiac output normally is about 5 liters of blood per minute, right? On average at rest. So cardiac output is approximately 5 liters. Their heart rate, stroke volume is the one we don't know right now. Bear with me here. Nope, that isn't the right one, Mary. There. It's 110. Now coming back, looking at this question. What affects venous return? Blood volume, skeletal muscle, and sympathetic nervous system. Actually, I'm going to back up. I'm going to back up even further. If they have a low blood pressure, what affects blood pressure? Major things that affect blood pressure. Cardiac output times total peripheral resistance. What affects total peripheral resistance? Arteriolar radius and blood viscosity. One thing that's not, let's see, blood volume also is going to be total peripheral resistance, blood volume. Bear with me. bear with me here. I'm sorry, I'm a little brain dead all of a sudden. 3 things: blood viscosity or blood volume, vessel length, and the vessel radius. Which one is most affected here? And rather than saying resistance here, Louis, stop it, buddy. Which one is most affected here that would affect the resistance? Casey, tell me which one was most affected. Overall, do you think that their vessel length all of a sudden became significantly shortened?
Yeah.
Why would you say that? Why would you say that? Casey, she's gone.
Would it be the blood viscosity?
Yeah, think of it as blood volume, not so much viscosity, because realize that blood volume itself is going to result in resistance. And so looking at this, the only thing that's going to, unless, all of a sudden they lost a lot of blood vessels, which I'm guessing they didn't. The only thing that's going to be affecting them most drastically is blood volume. And if they have less blood volume, they have less stroke volume. And if they have less stroke volume, their heart rate has to go up to maintain a cardiac output of 5 liters per minute. Does that make sense?
Yeah.
Okay. So that's why, so what that is, and I'll tell you, that's typically where I run. That's where I get those numbers so easily. It's typically where I tend to run. And part of it is because I don't drink enough water and I drink way too much caffeine. But vessel radius, the autonomic nervous system, and blood pressure. So you elevated blood pressure. Arteries get stretched, like the carotid artery, carotid artery and carotid sinus and the aortic arch. Those baroreceptors start to fire. They increase in their fire rate. The cardioinhibitory neurons get stimulated, resulting in vagus nerve firing. Vagal tone meaning vagus nerve firing. Remember, that's a parasympathetic slowdown. And the result is reduced heart rate. Baroreceptors increase their firing and vasomotor centers get reduced, resulting in reduced sympathetic nervous system constriction. Results in reduced vasomotor tone if you have less constriction, resulting in increased vasodilation, resulting in reduced blood pressure. Is this clear?
Yes.
Last part, one of the last parts. 4 different types of shock. Hypovolemic shock is where you have reduced intravascular volume because the heart is not the cardiac output has gone down. Louis, hey, what are you doing? So he's more attached to my mother than he is to me at this point. He just kind of thinks of me as maybe someone who might be important every once in a while. He started growling when you left. So hypovolemic shock, reduced intravascular volume because reduced cardiac output. Often this is where you get, if you have reduced volume of blood, all of a sudden you get reduced stroke volume. You get, hey, shh, hey, Louis. Buddy, stop that. Gotta let the whole world know. Hypovolemic, meaning the blood volume is dropped. The result is just like we saw up here. You have lower blood volume, so the heart rate goes up. This JVP has to do with jugular venous pressure. Right now, just realize it's going down. Cardiogenic shock is intracardiac dysfunction resulting from reduced output. Heart rate goes up again. In all the cases, heart rate is going to go up. Because you're still trying to maintain that cardiac output. The only one where the pressure is dropping is hypovolemic because you've lost a lot of blood volume. So cardiogenic shock, increased heart rate, increased pressure, the peripheries are cold. Peripheral organs are cold. Obstructive shock caused by obstructing or restricting the cardiac output. You see it? Do you see a trend here? All of these shocks are the result of reduced cardiac output. The heart rate goes up, the blood pressure goes up, and the peripheries are cold. Pressure is going to go up because you're going to try to bring the stroke volume up at the same time that you're working on the heart rate. It's not going up here because you've lost a lot of the volume when you don't have the volume of blood to work with anymore. That's the reason it's going down here. Distributive shock is when there's severe vasodilation, meaning you have no peripheral resistance. And therefore the heart rate goes up and the pressure is also going to try to go up. Other questions? So it's all related to the fact that there is a reduced cardiac output. And as a result, and it's coming because of the stroke volume. One way or another, it's coming because of stroke volume. So shock, blood pressure, blood pressure drops. Wait, bear with me here. Cardiac shock. Why did I put this in here? Let me see here. For shock to reverse it, blood pressure is going down, cardiac output is going down because stroke volume is going down. So the purple lines are compensating factors. The red is showing what the shock caused. So shock, reduced blood pressure, reduced cardiac output, reduced stroke volume. As a result, compensation increase the blood pressure by increasing the resistance to blood flow, by increasing the vasoconstriction through the catecholamines, the sympathetic nervous system, and increasing levels of ADH and angiotensin. Any questions? Edema, swelling of the tissues, occurs when there's too much interstitial fluid. So there's a reduced concentration of plasma proteins. This would be like the guy in liver failure. Reduced plasma proteins leads to an increased permeability. So there's increased permeability, meaning you're losing a lot of fluid from the vessels out into the tissues. And you also don't have as many proteins in the plasma to start out with. So you have less abilities to pull that fluid back in to the vessels and get it reabsorbed. This can come from increased venous pressure, meaning a backup of the veins, and blockage of lymph vessels. Because remember, some of this fluid that doesn't get reabsorbed is going to get pulled back into the bloodstream via the lymph vessels. Questions? This was that diagram that we went through earlier, showing just the different distribution of exercise versus at rest.
I found that question, by the way, in the
What?
smart book, the ADP
Yeah.
question.
Yeah.
I found it. I took a picture of it. But no, it's in there, and it was right. You were right.
I wasn't right initially, but good.
That's okay.
I'm glad.
It's a lot of information to keep straight.
Well, I get better with time, but everybody does. So true or false? Increased capillary filtration, reduced reabsorption or obstruction of lymphatic drainage can lead to edema. True or false?
True.
True. Vasomotion, remember what vasomotion is, can raise or lower blood pressure throughout the body.
True.
True, correct. Blood flow through a capillary bed is regulated by precapillary sphincters.
True.
It's true. It's true. The pulmonary circuit is the only route in which the arteries carry less oxygen than veins.
True.
That's true. Good job. You guys, that is the end of that. And your first exam, which covers the last 4 chapters, I wanted to do them all together because I think they go well together. And your other exams will not cover this many chapters. But, and I'm thinking about, we'll decide as the semester goes on what I change and what I adjust. Because, yeah, we'll just see. But right now, your first exam will open in probably around 5 p.m. tonight. Your third lab quest will open at the end of today. Actually, I think it's already open. It might be. Let's move into the pulmonary system.
When is the first exam due?
Let's make it due. I'm not going to make you do it over spring break if you don't want to. Next, a week, 2 weeks from last night. I can't remember what day that is.
The 24th.
The 24th. Let's make it do then.
Okay.
Your bear with me here as my brain all of a sudden got fried. Your midterm grades will be posted on Monday. I think that at actually they'll be posted probably on Tuesday. Anything that was due up until last night will be included in your grades. And let's, oh, what else? Oh,
Sorry, I have a question.
yeah.
Would you be able to open up the Wiley questions again? I was doing them
If-
last night. I literally fell asleep while I was doing them because my car got towed.
If you,
My car got towed, so it was like a whole
Ouch.
mess last night,
well,
and I
that's-
was like,
that
Yeah.
sucks. Lauren, send me an email and tell me which ones and when you think you'll have them done by, okay?
okay, thank you.
Now let one other thing. I'm going to send out your urinalysis strips. I don't have everyone's information. I'm pretty sure I don't. I'm going to list off the names of people I have.
I tried texting you like last week because I had a doctor's appointment in the morning, so I wasn't gonna be in class, but it said it was a house number. So I don't know if I
It
the right-
shouldn't be a house number.
I know it was really weird, but I don't know.
It's 952-201-3126.
Can you repeat that one more time?
952
Mhm.
201
Mhm.
3126.
Okay, I will try texting that one again.
Yeah. So let me tell you who I have. And if you sent it to me before, I didn't write these down for a couple of weeks. I was slacking. And when I finally wrote them down, this is who I have. So if you've sent it to me before, please just resend it to me. But I have Jenna Lynn. I have Carrington. I have Catherine Maldonado. I have Safa. I have Toyin. I have Claire. I have Zena. I have Kevin. I have Alexa Keeter. I have Jade. I have Casey. I have Rachel, and I have Becky. If you're not on that list, I don't have yours. And if you want to be able to participate in that, I need it. What I'll probably do is I'll send you, probably send you 4 strips because I should easily have enough for four per person. And I'm going to give you some recipes to make urine, make a made up urine. And I'm going to send you enough for, I think, all of the recipes and one for yourself if you want to do your own. And we'll talk about what those values mean. But yeah, so that's what I need. If I didn't read off your name there, I don't have it. I'm realizing like one of you lives like right next to me. I could probably walk to your house and didn't realize that. Because we seem to be really spread out, but I'm like looking at the address going, that looks really close to my house. But I'm still going to put it in the mail. And like I said before, as soon as I put them in the mail, I shred them afterwards. I'm not going to keep your addresses around. It's a HIPAA violation, and I wouldn't keep them. Excuse me, not HIPAA. Well, it's kind of HIPAA too, but it's a FERPA violation, and I don't keep them around. But let's jump into the lab. What? I'm not surprised he's growling. You're his favorite. It's not me. He puts up with me when you're not home. So pulmonary respiratory systems and structure and pulmonary ventilation. You'll also see you have 2 virtual labs for this lab. Also, so respiratory system functions, major functions, breathing, as the pulmonary ventilation describes breathing. It's actually the amount of air moving in and out of the lungs. It defines pulmonary ventilation. The air moving in and out of the lungs. It involves inhalation and exhalation. Gas exchange. External respiration. So this is important here. External respiration is gas exchange between the lungs and the blood. Internal respiration is gas exchange between the lungs and all the interstitial tissues. So pneumonia that's going to affect gas exchange in the lungs does not affect internal respiration overall. It's going to affect it because it's going to reduce external respiration, but it's not going to affect internal respiration until external is first. Immediately, it's going to affect external respiration. It's going to affect internal respiration next, just by a trickle-down effect. So external respiration, gas exchange between the lungs and the blood. Internal respiration, gas exchange between the blood and the other interstitial tissues. Sound production and olfaction. So the respiratory system is divided into 2 categories. The upper respiratory tract, which includes your paranasal sinuses, your nasal cavity, and your pharynx. And your lower respiratory tract, which includes your larynx, your trachea, your bronchi, and your lungs. Your upper respiratory tract is divided into two things. And you guys remember, do me a favor, bear with me really quick. Do me a favor and remember this. When you're filling out, you'll see you have a lot of questions this time. because there's a lot of information here. But when you're filling out the places where it says drop, what's this structure, what's that structure, what's the structure, what's that structure? Every one of those questions, every one of those figures, the answer is in the PowerPoint. And the exact correct answer is in the PowerPoint. So make your life easier and my life a little, first off, make it worth how much, there's a lot of time that goes into doing that. My mother can tell you that I was at Stevenson until really late the other night, trying to get that done for this class and my other class. So make the effort that I try to make your life a little easier by doing that. And so please use them and recognize that they are all there. So upper respiratory tract divided into the nose and nasal cavities. Was there a question? Sorry. Upper respiratory tract divided into the nose and the nasal cavities, the paranasal sinuses and the pharynx. The nose is the main conducting airway, supported by paired nasal bones superiorly. Most often, when someone breaks their nose, it separates the cartilage. Unless it's a really good break and breaks the nasal bones up here on top and the septal, this nasal septum that separates the two halves of the nose. Or it's a deeper break where you're breaking the bones underneath. If it's a superficial break and doesn't break the nasal bones, you're separating the cartilage. But cartilage, as we know, takes a really long time to heal because it's avascular. So the nose is the main conducting airway. So upper respiratory tract includes the paranasal sinuses, the nasal cavity, the nostril, the hard palate, the soft palate, the pharynx, the oral cavity, which is not included because people don't predominantly breathe out of their mouth on generally. So nasal cavity begins as an internal component of the nose and ends as the openings to the nasal pharynx, known as the internal nares. So looking here, it starts right here and it ends right here, nasal cavity. The nasal septum divides the nasal cavity into the right and left portions, with the middle and superior middle and inferior nasal concha. They look like little shells. Little shells look like little plain shells. That's where the word concha comes from. Form the lateral wall for each cavity and function to condition the air within the nasal cavity. This is important later. So they're conditioning it by humidifying it, not so much conditioning it, AKA humidifying the air within the nasal cavity. Warming it up and humidifying it. So internal nares, superior nasal concha, middle nasal concha, superior nasal concha. Underneath each one is a meatus, a canal. The inferior nasal meatus, the middle nasal meatus and the superior nasal meatus. External nares, internal nares back here. Nasopharynx is right here. So internal nares coming back, shifting a little bit more posteriorly and including the part of the oral cavity. The palatine tonsil. Oh wait, bear with me here. The internal nares, soft palate. The pharyngeal tonsil. Right here in the very right next to the nasal pharynx. The opening of the auditory tube. Remember from last semester what the auditory tube was, if you had me especially. Because we only covered one special sense. I was told to just pick one. And I use hearing imbalance because that's what I'm most familiar with. So the opening into the auditory tube, this is the tube that connects with your middle ear. You remember that from last semester? So that's going to be in your nasal pharynx. The location of that opening in the auditory tube is in your nasal pharynx. The uvula, a little hanger downer thing in the back of your throat on your soft palate. The oropharynx, oral meaning mouth. So this is the part, this whole area right here is your pharynx. Here's the nasal pharynx right behind the nasal cavity. Here's the oropharynx right behind the oral cavity. And here's the laryngeal pharynx right next to the larynx down here. Palatine tonsil on the soft palate, lingual tonsil, lingual meaning tongue. So lingual tonsil right at the base of the tongue. You can understand why people who have inflamed tonsils or get their tonsils removed because they block breathing. So looking at the sinuses, the frontal sinuses, remember these are cavities within the bone. The frontal sinuses, meaning a cavity within the frontal bone. The ethmoid sinus, meaning a cavity within the ethmoid bone. Sphenoidal sinus, cavity within the sphenoidal bone. Maxillary sinus, cavity within the maxilla. This is the one diagram that I found, and I haven't seen one of these in a while, that is so obviously wrong on your questions. It was a really good question. Do me a favor. If it marks you wrong, does it just let you go forward if you miss a question? It does, doesn't it? It's going to mark you wrong. I'm warning you right now, it's going to mark you wrong. Because I can't remember exactly how they had it labeled in there. But it's wrong. Because I was like, this is not, I kept looking at it and I kept thinking, well, if I look at it from this direction, I look at it from that direction, is it right? And it's not. I have it labeled approximately right here. It's a good diagram because it's showing the nasal septum. It's showing the inferior nasal concha. It's showing the middle nasal concha. Up a little further is the superior nasal concha. It's showing the sinuses, but they have it labeled wrong. And so use what I'm telling you more than what they're trying to tell you is right, because it was really strange that it was just wrong. The pharynx. So this is the nasal pharynx right behind the nasal cavity, includes the auditory canal, auditory tube, the opening of the auditory tube. The oropharynx right behind the mouth, and the laryngeal pharynx. So the nasal pharynx, main function, it conducts the air. It's made of pseudostratified ciliated columnar epithelium. It's got the pharyngeal tonsil on the back wall, and it's posterior to the nasal cavity, and the openings for the auditory tubes are also there, which help you equalize the pressure, air pressures in the middle ear. Oropharynx conducts the air, serves as a passageway for food and drink. You guys, if you didn't have me last semester, let me spend a minute longer with the auditory tubes. So this is a hole that's linked from your middle ear into your nose and throat. This is one of those main reasons why ear, nose, and throat doctors are around, is because they're very highly interrelated. This is why you can get your ears to pop most times when you yawn, if you need to equalize the pressure in your ears. It's because you open that tube. And that allows you to equalize the pressure in your mouth with that of your middle ear. So oropharynx conducts the air and serves as a passageway for food and drink. It contains non-keratinized stratified squamous epithelium. It's posterior to the oral cavity, and it's got paired palatine tonsils. Lingual tonsils on the base of the tongue. The laryngeal pharynx contains non-keratinized stratified squamous epithelium, and it extends from the level of the hyoid bone to the beginning of the esophagus. Now, so that was the upper respiratory tract. The lower respiratory tract is composed of the following: the larynx, the trachea, the bronchi, and the bronchioles. So the larynx, trachea, the bronchi, and the bronchioles. Different structures. So the larynx, I'm just reading some of the information that I think is more important than others. The larynx functions in conducting air and prevents ingested material from entering the trachea. So this is where your epiglottis is. And it's going to produce sound and assist in increasing the pressure in the abdominal cavity for when you sneeze or cough. The trachea is this flexible ring of fibrocartilage. I think it's fibrocartilage rings that conducts air. The bronchi, largest airways of the bronchial tree, consists of main or primary, lobar, secondary, tertiary segmental, and smaller bronchi. And it conducts air. Bronchioles have no cartilage in them. I don't know how correct that is. We'll go with it for right now. No cartilage in them. And conducts the air, and smooth muscle in the walls. Yeah, I guess it could be correct. So smooth muscle in the walls is going to allow for bronchoconstriction and bronchodilation. If you have cartilage in your bronchi, you can't constrict, right? Vasoconstriction is not going to happen. Bronchodilation and bronchi dilation and bronchiconstriction are not going to happen if you have cartilage holding your bronchi open. So the only place where you get bronchoconstriction and bronchodilation is in the bronchioles, because they don't have cartilage around them to hold them open. Respiratory bronchioles, main purpose is gas exchange. Alveolar ducts, gas exchange. Alveoli, gas exchange. Respiratory bronchioles are made of simple cuboidal epithelium. Alveolar ducts are simple squamous epithelium. Remember, cuboidal looks like cube-like cells. Simple squamous is flat cells. They're both single layer. Alveoli, simple squamous epithelium. So the larynx, also called the voice box, connects the pharynx to the trachea. Serves as a passageway for air and prevents ingested materials from entering the respiratory tract. Produces a sound for speech and assists in increasing the pressure in the abdominal cavity, and participates in both a sneeze and cough reflex. It's supported by a framework of 9 cartilages that are held in place by ligaments and muscles. The ring-shaped cricoid cartilage is inferior to the thyroid cartilage. The epiglottis is a spoon-shaped cartilage that projects superiorly into the pharynx. And swallowing will cause the epiglottis to close over the opening, and actually not to the larynx, close the opening to the trachea. That's a typo right there, trachea. The following paired cartilages play an important role in sound production. The arytenoid cartilages, the corniculate cartilages, and the cuneiform cartilages. So looking right here, here's the hyoid. This is anterior view. Here's the hyoid. Here's the epiglottis peeking up over the top, and it's on the posterior side. The thyroid cartilage, you can feel it on yourself right here. The cricoid cartilage right below it. The thyrocricoid ligament is where they do tracheostomies. Right here, that's not labeled. An epiglottis. So looking at the posterior view. If you look, and you don't see it really well here, but the cricoid cartilage surround is the only full circular cartilage of the trachea. As my mother's correcting me, cricoid cartilage. Don't mess with the best, guys. Just say whatever she wants goes. So cricoid cartilage. You know, nobody's corrected me all year, Mother. Okay, so cricoid cartilage. Here's the cricothyroid ligament. Epiglottis, thyroid cartilage, and the cricoid cartilage. Cricoid cartilage is the only full ring. All the other cartilage of the trachea are C rings, where they're open in the back. Looking at an interior mid-sagittal section. Here's the epiglottis. Bear with me here. We don't see it here, but right here, this would be where the thyroid cartilage would be. Thyroid cartilage right here. Actually, it's right here. Thyroid cartilage right here going up like this. The arytenoid cartilage looks like a horn. If you look at it, here's the handle. Here's the, actually, here's the handle. Here's the rest of it. The corniculate cartilage is on the tip of the handle of the horn. And the cuneiform cartilage is up closer to the epiglottis. Now, here's the vocal fold. Here's the ventricular fold. This is what makes sound. So right here is the cricothyroid ligament. If this is where you make sound and these vibrate, can you understand how a botched tracheostomy would result in loss of your vocal cords? Since they're right here and the cricothyroid ligament is right here, this is where you do a tracheostomy. If you're familiar with Stephen Hawking, and most people have heard the name Stephen Hawking. Have you heard the name?
Yes.
Okay. What happened with what he had was early onset Lou Gehrig's disease, and he got diagnosed when he was 21. And at that time, they didn't know what it was. And they told him that he had two years to live. And didn't realize that there were two different kinds. Late onset and early onset. And he had early onset. And during one of his seizures, he quit breathing. And at that point in medical time, they didn't realize, bear with me here as I'm trying to put my sweater on because I'm cold all of a sudden. And I'm putting it on. They didn't realize they didn't know how to do a tracheostomy without botching the vocal cords. And so when it happened, they actually were going to let him die. If you've watched the movie The Theory of Everything, they were going to let him die rather than do the tracheostomy, because they didn't know how to do it without botching the vocal cords. And his wife threw a fit and said they weren't going to let him die. And that's the reason he no longer spoke afterwards. Is because it essentially was a botched tracheostomy. I really like Stephen Hawking. If you can't tell, the guy was absolutely amazing. I don't agree with some of what he said overall, with some of his conclusions about life in general, but he was amazing with what he discovered and how he conceived it and put theories together and discovered things that we would have never seen, discovering black holes, discovering the Big Bang Theory, which science is continuing to prove is most likely how the universe started. But vocal cords. So vocal cords are found in the larynx and are composed of vocal ligaments covered by a mucous membrane. Here's the ventricular fold. Here's the vocal fold. Oftentimes we would call the ventricular fold a false fold because it looks kind of like the vocal fold, but it isn't. Wiley specifically distinguishes between the two. So this is your ventricular fold. This is your vocal fold. So looking up here, this is your ventricular or your false fold. This is your vocal fold. So the opening between the vocal cords is the glottis, which is essentially the opening into the trachea. When the air is forced through the glottis, it causes vibration of the vocal folds, which results in the production of sound. So when the folds are abducted, when they're open, they vibrate. A smaller or lower sound is going to result from adducted vocal cords. Remember that abduction meaning to pull apart or move apart from each other. Adducted meaning to come together. Here's the arytenoid cartilage. Here's the corniculate cartilage. Here's the thyroid cartilage. Any questions so far? What time is it? Let's keep going for a little bit longer here. So trachea and esophagus, referred to as the windpipe. And it's anterior to the esophagus. This is what you can feel right here. And if you feel, you can feel the C rings. You can feel the individual C rings all the way down. It's anterior, so it's in front of the esophagus and inferior to the larynx. So below the larynx, and superior above the main bronchi. Right on the very back, where it's, remember, the only complete ring of the trachea is the cricoid cartilage. So on the back of each C ring, there's a trachealis muscle, which covers the back of the trachea all the way down. The esophagus is right here, right behind it. The reason you have those C rings is so that the esophagus can expand as you swallow something. And you can get a little bit of a stretch here. So posteriorly, the ends of the tracheal cartilages in the back are connected by that trachealis muscle. And the mucosa in the trachea is lined with pseudostratified columnar epithelium and mucin secreting goblet cells. Remember, goblet cells secrete mucus. You guys, let's stop right here and take like a 5-minute break and come back to right here. I don't care what you do as long as you look. She would have to do it to you. That will win out. If you did it to you, you'll have it. I'm not sure she will just call and get it out. I know. Leave me out here all by my own for hours. Oh, I got some straight cheese, fried. So, anyway, so you try and tell me what you see. Why don't you stick them in the freezer? I don't fulfill that fast. To make some meatloaf. All right, so let's come back to right here. So looking at the right and left lungs, the apex is the tip and the base is the bottom. The right lung has 3 lobes, the inferior lobe, the middle lobe, and the superior lobe. The left lobe, excuse me, left lung has an inferior lobe and a superior lobe. And the cardiac notch, which is where the heart is going to actually sit in the cavity there. Looking at the medial view of both lungs, the hilum is where the bronchi and arteries, veins, and lymphatics are going to enter the lungs. Remember, the left lung has a superior lobe and an inferior lobe, and the right lung has a superior lobe, a middle lobe, and an inferior lobe. And at the pleural cavities, so the lungs located in the pleural cavities on the lateral sides of the thorax, separated by the mediastinum. The visceral pleura adheres tightly to the outside of the lung. And the parietal pleura lines the pleural cavity itself. So let me put this a different way for you. The visceral pleura is on the outer, so it lines the outer side of the lungs. The parietal pleura lines the inner rib cage. I want you to think of it that way for a reason. So visceral pleura lines the organs themselves, lines the lungs directly on the lungs. The parietal pleura lines the rib cage. This is really important that you think of it this way. These two membranes are continuous with one another with a space between them, a very, very small space called the pleural cavity. There's really, that cavity almost doesn't exist.
So the cavities in between the two?
Well, and it's not really there. That's the thing. I want you to understand that it's you really almost don't have a pleural. You don't really have a pleural cavity. You've got a little bit of fluid there that kind of sucks them together. But there's very little space there. It's not like the heart where it's loose, the parietal pericardium, the epicardium, the parietal pericardium and the visceral pericardium, how they're not very loosely, they're not attached to one another at all. These are much more attached. And the reason is because the visceral pleura is sucked onto the parietal pleura under a negative pressure. Does that make sense why I'm telling you there's really not much of a cavity there?
It does, but will this be a random? We still have to know that it's in between.
I mean, understand that would be where that space is, because when you get a pneumothorax, guess what happens?
You have a collapsed lung.
Well, guess how it happens? The visceral pleura separates from the parietal pleura. And that will make more sense in a moment here. Understand that there's a cavity there theoretically, but
Okay.
it's so small because it's sucked onto it. The visceral pleura is sucked onto the parietal pleura. That will make more sense in one moment here. So intrapleural pressure and alveolar pressure, or intrapleural pressure meaning in between the two pleura, alveolar pressure or intraalveolar pressure or intrapulmonic pressure. Boyle's law and Dalton's law. So pressures, we have different pressures here. Remember, everything moves from a high to a low, right? So you have atmospheric pressure, which at sea level is 760 millimeters mercury, or torr. You have intraalveolar pressure, which is like under a vacuum. And it's -4 millimeters of mercury. Intrapleural meaning in between the pleura. The intraalveolar pressure is the pressure within the alveoli and within the lungs. So atmospheric pressure, 760 torr. Intrapleural pressure, negative pressure of 4. Intraalveolar is the pressure within the alveoli. With that in mind, some basic laws of pressure. Boyle's law says that if you decrease the volume of something, you increase the collision of molecules and you increase pressure. So let me put it a little differently here. If you decrease the volume that a gas is in, you increase the pressure. Does that make sense? So if you decrease the pressure, by decreasing the volume, you increase the pressure, right? That's Boyle's law. So if air is going to move from a high to a low pressure, what do I have to do to increase the volume of my chest or decrease the volume of my chest to get air moving in and out? Just help me out here. I want some comments here. Help me with some suggestions.
Take a deep breath.
Well, how does that do it? Well, how does that work? What,
Because it would
does taking a
increase,
deep-
it would increase your chest cavity, which would increase the volume inside. So it'd be less pressure.
Yes. And so at that point, what's going to happen with the air that's outside of your lungs versus inside your lungs?
Decrease. Outside would decrease, the inside would increase.
No, wait. Step back. So if I increase the volume of my chest, what happens to the pressure within the chest in comparison to outside?
It increases. Wait.
If I have the same amount of air in my lungs right now, and I take a deep breath, before the air moves anywhere, what have I done to the two pressure differences? What is it outside? What is it inside? Before air moves in.
It's not equal.
It's not. And so the whole reason the air actually moves into your lungs is because you've decreased the pressure in the lungs. And the result is that the air moves into the lungs. Does that make sense?
Yeah, when it's explained that way, yeah.
That's how you want to look at this. So how are you going to increase the pressure in your how are you going to expand out your lungs? What do you do to actually expand out your rib cage?
Take a deep breath.
Well, how do you do that? What muscles are involved?
Intercostals,
Intercostals and what else?
diaphragm.
Okay, so intercostals and diaphragm. So we have to contract our external intercostals and our diaphragm. Why do our lungs expand with them?
Because it has to do with atmospheric pressure.
Nope. What did I say here about the visceral pleura and the parietal pleura?
Oh, because there's a muscle like attached to the pleura.
Nope.
No, I'm getting it all.
What did I say here? The visceral pleura lines the lungs.
Yeah.
Parietal pleura lines the rib cage, and they're sucked on one another. So if I expand my rib cage, which expands my parietal pleura, my visceral pleura is attached to it and it expands too. Does that make sense? Because they're under negative pressure, just like your vacuum in your house. That's the reason I want you to look at the visceral pleura and parietal pleura like that. Is because if I expand out one, the parietal pleura, the visceral pleura that's sucked onto it under a negative pressure is also going to expand. And that's going to pull apart the volume of the lungs or increase the volume of the lungs, right? And by doing that, what happens is I decrease, like Becky said, I decrease the pressure within the lungs. And then the air moves in because it's higher, the pressure is higher outside of my lungs than it is inside. And so air moves in. Well, what happens when I breathe out?
It's the opposite. The visceral pleura and the parietal pleura decrease.
Yeah, well, the parietal pleura collapses, and because the
Right.
visceral pleura is sucked onto it, it collapses. What does that do to the pressure within the lungs?
Collapses until
It collapses? It, so,
Contract.
well, what's that gonna do to the pressure? So
In-
it increases, right?
Right.
It increases. And the result is that the air goes out because it's higher inside the lungs than it is outside. That's how you breathe. Does that make sense?
Mm-hmm.
I think that's awesome if you think of it that way, because you really don't consciously do a whole lot. What you're doing is increasing the pressure or decreasing the pressure in the lungs, and that's causing the air to move in or out of the lungs. One other law that's important here is because we have to have a certain amount of air. We have to have a certain amount of oxygen. Well, atmospheric air is a composition of a lot of different gases. And if at sea level, excuse me, at sea level, we're at 760 torr. I'm going to write down some information. Well, I was going to until I left my pen somewhere. So 78% of the air in our atmosphere is nitrogen. 21% is oxygen. 0.404% is carbon dioxide. 0.04% is water vapor, right? When I'm looking here, let's see here. So 706, all of the air, all of the different gas molecules, they each have their own pressure. They're each contributing to the 760 torr. So all of the different types of gases altogether have a contribution to the pressure, air pressure of 760 torr at sea level. They each are involved. So when I'm looking, let's see here. So how do I determine how much of that air pressure at sea level of 760 torr is coming from oxygen? (760). Remember the percentage of oxygen in our atmosphere is 0.21. So what is 0.21 times 760? Or 760 times 0.21?
It's 159.6.
Okay, so that's the pressure of only air in the atmosphere. Carbon dioxide is 0.0000, that's an O, 4.
So that would be
what's that one?
3.04.
3.04. So between 3.04, looks really terrible, but that's 3.04. If I add those together, those are the two gas pressures of both. That's the sum of the gas pressures of oxygen and carbon dioxide within the atmosphere. I can do it for all of them. So 760 for nitrogen is 78. What's 78 times 7.60?
It's 0.78.
Yeah, 0.78.
So it would be 592.8.
592.8. Now, I add those together. So 159.6 plus 300.04 plus 592.8. What's total?
755.44.
So what that says is that of the 760 torr at sea level of air pressure, 755 something,
44.
44,
Mm-hmm.
of the 760, the nitrogen gas, the carbon dioxide gas, and the oxygen gas add up to produce 755.94.
44.
Thank you, 0.44.
Yep.
The rest of the gases make up the rest. So each gas contributes its own partial pressure to the total atmospheric pressure. This is what's defined as Dalton's law. Now, what happens if we're not at sea level? So we're not at sea level. Let's say that now we're at, bear with me here. Now, rather than being at sea level, we're at 760. We're now 2,000 feet above sea level. So the atmospheric pressure is now 707. If you take 707 and divide it, times it by 0.21, you get an air pressure in the air of 148. It gets humidified within the nasal cavities, and that drops it down, the air pressure down to 97. Does that make sense? And every pressure gas adds to the, has a partial pressure that adds to that sum of 707 or 760, based on the percentage of that gas within the atmospheric air. Is this clear? So now I'm going to move forward. And we kind of already talked about this. Classified muscles involved in quiet breathing. Oh, we didn't really. So muscles that are involved in the respiratory system. Quiet breathing, forced inhalation, and forced exhalation. Skeletal muscles involved in the breathing include the diaphragm, the external intercostals. This is where your phrenic nerve and your intercostal nerve stimulate these muscles to contract. And when those muscles stop contracting, then they relax. That's when you exhale. This is quiet, normal breathing, only involves the diaphragm and the external intercostals. The sternocleidomastoid and scalenes are forced inhalation, which is where, rather than just doing quiet breathing like right now, now we do forced inhalation. That's your sternocleidomastoid contracting and your scalenes to force your chest cavity to enlarge even more. And so in out breathing, forced expiration is going to involve your internal intercostals and your abdominal muscles to shrink your rib cage beyond what it would normally be. So internal and abdominal muscles. Here's your rib cage. And now rather than have it be really, really, really expanded out, you're going to force it out rather than just relaxing your diaphragm and your external intercostals. You're contracting your internal intercostals and your abdominal muscles to force your chest cavity to be even smaller than it would when you're just quietly breathing, increasing that pressure even more, causing the air to move out. Is this clear?
So if you live with a snorer, they're using their sternal clastoid mastoid muscles.
Most likely, or more, or they're also possibly using their abdominal muscles. Because they're struggling both directions, getting air in and getting air out. My cousin was born with the umbilical cord wrapped around his neck 3 times. And they didn't recognize until he was out that it was wrapped around his neck. And as a result, he came out blue. This was like, oh, I don't know, 35 years ago. And they didn't realize that it was wrapped around his neck like that. And so he came out not breathing at all. And not having any ability to breathe. And as a result, yes, he survived. He's now a happy father of like 2 or 3 kids. But when he was really young, he had the most amazing 6-pack you'll ever see on a 4-year-old. Because I remember his brothers would pick him up, and you've seen little boys, little 4-year-old boys and girls, they have this little enlarged stomach, kind of, little protruding stomach. Well, they would pick him up and he would have this absolutely defined 8-pack all the way down. Because every time for years after, for easily 4 or 5 years after he was born, for him to breathe out, he was using those abdominal muscles and internal intercostals. And his dad could hear him from several rooms away when he snored at night. So it's both. So looking at the different muscles, the sternocleidomastoid, external and internal intercostals, diaphragm, rectus abdominis, external oblique, internal oblique, transversus abdominis. Pulmonary ventilation, meaning breathing in and out. We talked about this earlier. So what you're doing is you're changing the pressures. So when you exhale, you shrink up the rib cage. When you inhale, you enlarge it. So the bellow jar model, this is something they frequently use to show parietal pleura and thoracic wall trachea. Here's your pleural cavity, here's your lungs. Lungs are covered with visceral pleura. This is under a negative pressure. Here's your diaphragm. So there is a pleural cavity, but the whole area is under negative pressure. Does that make sense, Becky?
Yeah.
So when you decrease the volume, the lungs shrink, and the pressure increases. When you increase the volume, the pressure decreases. And you guys, I want to go through this with you, but I don't. And the reason is because I want to get into the lung dissection. You are going to do you're going to see an animation with the lab that you can view that will help you answer questions. You also have this information. You also have a virtual lab that's going to ask you to do the same thing, very similar. I'm not going to go over it because I know you'll see it then. We'll also see it in lecture in a couple of weeks. Ventilation control by the brain centers. So the respiratory center in the medulla oblongata controls the rate and depth of breathing. The ventral respiratory group in the respiratory center controls inhalation and exhalation by the phrenic nerves and intercostals. The dorsal group, respiratory group, receives information from sensory receptors in the body and relays it to how to increase or decrease, whether you need to increase or decrease your inhalation and exhalation. So with both of these, the ventral respiratory group and the dorsal respiratory group are found in the respiratory center of the medulla oblongata. So right here, here's the medulla oblongata. Here's the dorsal respiratory group. Here's the ventral respiratory group. There's the pneumotaxic center. What I want you to learn, one interesting thing that I learned about this is that your dorsal and ventral respiratory groups are what opioids work on. You've heard of people who have gone into an opioid overdose and died. What they do is they stop breathing because opioids act on these groups right here. I learned this the hard way several years ago because after I wrecked my car, I think I've told you that before, and I broke my jaw. During that time that I was in ICU, I had an opioid overdose, a morphine overdose. And as a result, I stopped breathing. And I can tell you it was really, really quite painful up until I passed out. But I don't want to go into that. I'll just tell you this is where they're acting, is right here. The fun thing about physiology is that you learn all this fun stuff about how things and why things happen and how they happen. But opioids are acting on these and slowing them down. So most of your respiratory tract is your conducting zone. Most of your lower respiratory tract is your conducting zone. Your respiratory zone includes the respiratory bronchioles, the alveolar ducts, and the alveoli. The only place where gas exchange occurs in the lungs is in the respiratory zone. The bronchial tree is this highly branched system of air conducting passageways that originate from the main bronchi and progress through narrower tubes before terminating in the bronchioles and the alveoli. Bear with me here. So looking here, here's your tracheal cartilage. Breaks off into the primary or main bronchi, left and the right. The next time that they separate is the secondary. So first break is the primary, first division point. Second division point is the secondary. The third division point is the tertiary. So the way you can identify which trachea is which, and which bronchi is which, is by counting the number of divisions. Here's the primary or the main. Here's the secondary. Here's the tertiary where it divides 3 times. So the first one, the primary. Second ones, the secondary or the lobar. The tertiary, or where it's going to divide again, or the segmental, off into the bronchioles. Is this clear?
Yes.
So the trachea bronchi branches into the right and left main bronchi. The next, each main bronchi divides off into the, into the secondary. This is not right. So each main bronchi is going to divide off into the secondary. I'm going to fix this later. Each main bronchi divides off into the secondary. Each secondary divides off into the tertiary. The tertiary are going to divide off into the bronchioles. I'll fix that. Follow this pattern. Can't believe I've never seen that. It looks really quite strange. Innervation of the respiratory system. So sympathetic, this is specifically affecting the larynx, the trachea, and the bronchial tree. The lungs are under autonomic control. Sympathetic stimulation is going to result in bronchodilation. Parasympathetic stimulation is bronchoconstriction. My phone keeps going off. Respiratory zone. The lower part of the respiratory portion of the lower respiratory tract includes the respiratory bronchioles, the alveolar ducts, and the alveoli. The terminal bronchioles are going to branch off into the respiratory bronchioles. The respiratory bronchioles branch off into the alveolar ducts. And the alveolar ducts end in outpocketings called alveoli, where the walls are so thin, the respiratory membrane is so thin that oxygen and carbon dioxide diffuse between the air and the lungs. Pictures looking at the alveoli and the ducts. Respiratory bronchioles lead off into the alveolar ducts. Alveolar ducts lead into the alveoli. Gas exchange. So carbon dioxide moves down its gradient from the higher pressure in the blood to the lower pressure in the lungs. Oxygen moves down its gradient from the higher pressure in the lungs to the lower pressure in the blood. Last slide here. So carbon dioxide, how do you measure? This is the equation for pH, right? So what this equation says is that carbon dioxide can combine with water to form carbonic acid. Carbonic acid breaks down into hydrogen ions and bicarbonate. Hydrogen ions, remember, that's how you measure pH. And therefore, the more carbon dioxide you have in your body, the more acidic your body is. Does that make sense? So carbon dioxide combines with water to form carbonic acid. Carbonic acid breaks down into hydrogen ions and bicarbonate. pH is a measure of the amount of free hydrogen ions. So the more carbon dioxide your body has, the more hydrogen ions you have, therefore the more acidic your body is. Now, I'm going to show you how this works. So I have in this, this is calcium hydroxide. Okay. So it's a base. I'm going to add a little bit to this water that I have. Just a little bit, hopefully not too much. So I'm really good at adding too much, and then we'll be here for a while there. Now, so if I add a base to water, what happens to the water?
It becomes a solute.
Well, it becomes solute, but what happens to the pH of the water?
Oh, it rises.
And so it becomes more basic, right?
Like alkaline, yeah.
So I've got a piece of pH paper. I'm gonna put it in here. I know I was supposed to give some, oh, Zena, I'm gonna send you some pH paper. So right there, actually, I'm gonna add a little bit more. That didn't work very well. Let's add a little bit more. So that isn't really that great. Yeah, it definitely isn't. Add a little bit more. Okay, that's a good amount. So now I'm going to do the same thing. Now that's perfect. Now you see it's pretty blue, right? And blue, according to my sheet here, is about 12. Right? So it's very basic. Now, I have a color indicator here, pH indicator. This is phenolphthalein. When something is basic, it's pink. The phenolphthalein is pink. When it's acidic, it's clear. So I'm going to add just a little bit to it. Maybe 2 more. There. So you can see it's really, really pink, right? So very, very basic. Now, when you blow out, when you exhale, what are you exhaling out? The majority of it.
Carbon dioxide.
Carbon dioxide. So I'm going to sit here, I'm going to blow in this, and I'm going to move my computer back just a little bit so I don't do anything stupid and destroy my computer.
What do you hear?
So slowly the carbon dioxide's reactive with the water. It's taking a long time because I added a lot of base to it. But do you see that it's slowly lightening up? And so, you know what, just to do an intermediate test, let's see what it is right now. I'm just curious. So now it's actually about, pH of 8.
It looks better.
So every time you think of carbon dioxide for the next little while, realize it's an acid. Okay. Any questions? It's an awesome experiment and it's easy to do. I'm going to test the pH really quick and just see what it is at this moment. So right now it's at about pH of 7. All right, so now let me get out the lungs, and I've got it prepared. So it's just a matter of getting them out. I'm going to switch cameras, get rid of this thing so I don't dump it on my computer because I'm not very smart sometimes. All right, let's see here. Okay, you. Let's put you. Bear with me, I've just got to get myself suited up. I don't want to have blood on my clothes. Let me keep the straw. I'm going to use it. Bear with me just for 1 second as I get myself suited up. So I will tell you that fixed lungs and unfixed lungs, fixed lungs will never do real lungs justice, ever. Because what happens when you fix it is you make a bunch of covalent bonds between structures that would normally not be bound together, making everything really stiff. And that's the reason I love the fact that I was able to get some unfixed lungs. So I told you I got these from a butcher in East Berlin. A lot of blood, a lot of blood, a lot more blood than a lot of things have. And I actually drained some of the blood from them last night. So this is, that's just nasty. Here, all right. Mom? Mom? Would you be willing to assist? No, I need your help just for a little bit. She's like, no, I'm going to bed. Okay, so looking here. Here's the right lung. Here's the left lung. Actually, am I doing the reverse? Nope, I'm definitely on the right side. Here's the trachea right here. And actually moving up here, you can see two little vessels. And what are they? Oh, there's the esophagus. No, wait, is that the esophagus? No, that's not the esophagus. Right? I think I'm doing it the wrong way. I think this is the right side. Bear with me, I'm just getting myself oriented. Mom? Would you get me another pair of gloves? Okay. So here's, I had to switch it around because I was looking at the trachea. You always have to get yourself oriented right. This is the trachea. And therefore, and because I can feel the back of it right here where the C, remember how there's C rings? If this is the back, this has to be the front. And that's the reason I determined that that's the front. Oh, look, there's the artery. Holy cow. There's the aortic arch right there. I'm gonna do some tearing here. This right here this right here, this, do you feel how tight that is? That is the pericardial sac. And you can see it's really, really tight. But all of these right here, superior vena cava, oh, actually, no, that's pulmonary trunk. Pulmonary, is that the pulmonary trunk? That's that is the artery. That's the aorta. That is that has to be the pulmonary trunk. It's a pulmonary trunk. So moving back here. This is my aorta. I need another pair of gloves.
Okay.
Because I'm going to try to blow these up. We'll see what happens. I should have gotten more than one pair. You can see there's a lot of blood. On lungs, they're usually described as being sheets of covered in blood. Why would that be significant? You can see there's a lot of blood here. Why would that be significant?
Because it's getting oxygenated in the
Right. I
lung.
mean, why? That's the whole point of having lungs, right? Is to have lots of oxygenation. And so the reason the lungs are just covered in capillaries is for that reason, to maximize oxygenation. I told you these are more bloody than most things. My mom has gone to get me another, what is that? Oh, that's part of the heart. That's the atria right there. I almost wish I could refreeze these. I have another pair, so I don't think I'm going to. But she's gone to get me another pair. Because I'm going to try to blow up the lungs. We'll see how well this works. Sometimes it works great, other times it doesn't work at all.
Okay, I'm here, your assistant.
We're going to try to blow up the lungs. they left a lot of the heart here too, like the major arteries are here.
Oh, nice.
Yeah, I can tell you the only time I only looked at that when I froze these, I only looked at them long enough to make sure that that's what they were, that they were lungs, and that was it. But so I'm gonna actually try. I'm gonna stick a straw.
Here, let me do that.
Yeah, we're gonna stick a straw down the trachea.
No, that will not be. You have to get past the cartilage.
My
rings.
mom's gonna try really hard.
You can't. You have to get past the cartilage rings so you can close it down.
So we need to cut it a little bit.
So where's the
Oh,
cartilage rings and
Do I need a pair of scissors to cut it, Mom?
no, I just need to know. Those cartilage machines don't want to give up.
No,
But
they're
let's
tough.
go in like we did before.
I don't remember how we
to,
did it before, Mom.
We found a
hole.
hole.
We can cut a hole.
Yeah. We cut a hole.
Okay.
So find where, oh, here's a break off. There's an extension. There's a cartilage on that one.
Yeah, there it is. You can feel it.
So I thought,
You want me to cut it?
no.
Okay, she's
For
good.
just a minute. Because you have to be able to occlude it
Right,
above.
right.
You know, if we took that one of your bloodied gloves and put it through here as our obstruction, we were going past the obstruction.
We're stuffing plastic down the trachea. Don't mind us.
It's just an obstruction. That's what you do when you suck plastic into your lungs. Okay, your job is to hold it there.
Okay, I got it.
Where's my scalpel thing? Unless you want to cut it.
You can cut it. Aha. Doctor.
No. I don't.
All right, sorry, guys.
Thanks. You're so
So what
concerned.
she's doing is she's making a cut. So we cut off the trachea. So we
Okay.
stuck a plastic glove in there. And now she's making a little cut in one of the main bronchi.
Oh, sorry. Mary, quit laughing at me. It's really embarrassing.
Good thing you're doing it, but I'm not now. That I think about it. I almost feel like refreezing these.
You're really wonderful. They're
Oh.
a nice set of lungs.
Okay, guys, just a sec. We're still
We need a
working on
probe.
it.
Have you got a probe?
Right here.
There's the hole. Right there.
You need a bigger hole than what you have. for
I
this
may,
straw?
but I don't want it so big. that I
Paisley,
can't-
off.
Made it a little bigger. Now quit that. I don't want to blow on blood. Mary, quit laughing. You're laughing at me again. That should be big enough.
I may have some clotted blood in there and that's what's making it hard.
No, that wouldn't keep us from going through clotted blood, isn't that impermeable? You work with us on this. Now keep your finger out of there.
What do you want me to try?
No.
Oh.
Just want to follow the probe in. And pretend like we're, come on. There's our spot. There's our spot. That lung just keeps getting in the way. Hold this back. No, oh, you and your tender gloves. There's our hole. Come on, hold the probe. Probe is in. Straw is almost.
She did it.
There we
Okay.
go. Now,
Doctor. I'm sorry, guys, I made her. Okay,
cool.
do you see it?
Yeah, I don't think
Becky,
it is an angle the right
Becky, do
way.
you see it? All right,
Try again.
she's not saying anything.
Oh, sorry. I said, yeah, I did. I was on mute.
Okay.
Wish I
That's
could get-
crazy.
Mary, I don't think you're doing a very good job of including
I'm
the
sorry.
trachea.
I'm doing the best I can. Wow, that's better than what we got the last time.
It's crazy.
Yeah, look how it all pearlizes. Can they see that?
Yeah, I think. Can you see it pearlizing, Becky?
Yeah.
Yes.
Oh, that's fun. Let's do that some more. Is that enough?
You want to see more?
Sure.
Have to compare both lungs here. See if we can get that one high enough that it can be seen. It's even lightening up. See, it's getting oxygen.
Oh, wow.
Yeah, it's just this one little lobe that's doing it.
You're probably in a secondary.
That's probably true.
So you guys, the reason that that one lobe is because she's actually in a secondary, and as they branch off, they go to specific segments. And so
Okay.
the reason it's only one is she's in a secondary bronchi.
Does it help if we turn it this way a little bit?
Yeah.
To Mary, what did you do to my lung?
I'm sorry.
Now, what did we do? Okay.
Mom's doing a great job.
No, I'm glad she's doing it. I'm not.
Yeah, and when I get whatever dread disease is growing in this, and you get your inheritance early.
Yeah.
Maybe that was her plan.
You're right.
Oh,
You're
clever
right.
girl. Yes, okay.
Actually, and I don't know what specifically what lungs. I told my mom the other day when I actually got lungs, they had to say that I was doing it for hack, or they would not give them to me.
Wow.
So there's something specifically in lungs, I don't know what it is, that you
won't
have
let
to
you
be
take it.
approved.
Yeah. You done with me?
Yeah.
All right. Paisley, come on.
A lot of what we dissect here, I don't see a lot here. I can try. I actually have another pair of lungs, so I'm not that worried about. But if you feel this stuff, it is like marshmallow. It's very loose.
But it's not as, it's a little more less squishy than marshmallow.
Little less squishy than marshmallow. Looks like they cut somewhere right in there. But so if you can't really see them, but you see them there. Do you see the rings?
Yeah.
Let's try. Let's see here. So right here, right back here where back of the C rings is that trachealis muscle. And so the esophagus would line right along here. And I think might be what this is right here. Yeah, that has to be the esophagus. This right here.
Okay, Mary, you have to pause so that I can put in my plug.
Put in your plug.
Yes.
Okay, go
for
ahead.
Infection
Pause.
control.
Infection control.
I was just in washing my hands. All of you who are going into healthcare, what is the first, last, and ultimate rule of infection control?
Always wash your hands.
Woohoo! Wash your hands, wash your hands, wash your hands.
And if you're not sure, wash them again.
Absolutely. And the rule with gloves, take off your gloves, wash your hands, take off your
Yep.
gloves, wash your hands, take off your gloves, wash your hands. There are studies that show that nurses who took off their gloves, went to the next patient, gloved up, and did not wash their hands in between, transmitted infection to their patient, from patient to patient. And
Wow. That was her
my two
plug.
kids.
Thank you.
So right behind, so here's, hey, you guys, when you need to leave, just leave. You're all right.
Paisley,
Right here,
Paisley, who's been chewing up on me?
I did something and someone got a tissue.
They sure did.
Right here, this is the esophagus.
No, we were already out. So you're just fine.
Because I can't imagine what else that is, and it's right on the very back of those C rings.
I don't care.
Thank you, Mom.
You bet.
If you continue, right here, I'm just going to tear it. Right here, right here. Your best dissection tool is your fingers. So unless I really need to use a blade, I don't. And honestly, it's even easier with unfixed tissue. But so here, right, this is that carina, that dividing point. Right there to right there. Louie, stop it, buddy. Stop it. Stop it. So yeah, I mean, the tissue is just very loose and airy. It's amazing how soft it is because none of your other tissue is that soft. But I can fill down, if I continue to fill down, you get to the point of where you don't feel cartilage anymore. And that's when you know that you're in the respiratory bronchioles. There's a lot of clotted blood. Is there anything in particular you want to see? Anyone?
Nothing in particular, just enjoying the process.
So right here, I'm still, and I'm not sure, that looks really small for a main bronchi. But my mom was breathing into a secondary one because it was going into that specific lobe. It looks like he's a little misshapen. Because if I come down even further, you know how you always have anatomical variation? When I come down even further, then there's a dividing point right here. This is the carina. Because if that had been the carina up here, this wouldn't be extending down. Because this is where it's actually dividing off again. And there's one here and there's one here. So I can feel it moving all the way down here. And I'm just kind of following the cartilage by texture. So this is actually what this looks like. It was probably a side branch of some sort. And I'm guessing it was a secondary side branch because right here are the main bronchi. As you can see, it's going there. That's where my mom blew in. Where she blew in. But it extends down and it keeps extending down. And here they are right here, are the main bronchi. Well, you can see I've kind of separated it down there. So yeah, here's the main bronchi coming down here. So it keeps coming down, trying to get some of this off. And it's really tight. So there's, if you see that, do you see the hole, Tariq?
Yes.
So that is one of the bronchi.
Okay.
And I think it's a secondary. If this is a primary or a main, this has to be a secondary. Let's see. I'm going to see something. Nope, I can't do it. Never mind. So yeah, that's a secondary. This is another one that it's surrounded pretty good. But this is another one. There's actually two right there. If you look right there, actually, no, that isn't one. Never mind. So I think once, as I go down, I can still feel cartilage down here, which says that I'm still in tertiary or secondary bronchi. I think this would be a secondary, but I'm still trying to figure out why the carina is all the way down here when we were looking at one up here. But I think, so this is a secondary. So this right here has to be a secondary also. And as I feel down, you can still feel cartilage. And so I know that at this point I'm in tertiary bronchi. So right there is another bronchi right there. You can see how loose the tissue is. And so this lining, talking about this earlier, this is the visceral flora. Oh, you see the big bubble?
Yes, yeah.
I'm realizing my scissors are not very sharp anymore. But I can still Even right down here, I can still feel cartilage. So I know I'm still in cartilage. Which means that I'm still in, according to your Wiley, I'm still in tertiary bronchi. So yeah, the tissue just, it's very, very, very malleable. I'm going to make a measure. Oh, is that going to do anything? No. Here's another. This is going out to this lobe right here. The bronchi. Yeah, it's still bronchi out here. I can feel the cartilage. If you look here, you see the little hole, Terry?
Yeah.
So that's going into that lobe. It's going into that bronchial segment.
You're saying the little hole like in the middle piece of,
Yeah.
okay, yeah. I just wanted to make sure I saw it right.
Yeah. Not really. Okay. Or if I could cut it. Okay. If you look here, there's a bunch of other little holes here too. They're all going out to different places. Different segments. Yeah, I mean, I can still feel the cartilage all the way down here. All the way in here. There's another little hole right there. I can feel like there's a hole, there's one right here. I just can't manage to tease it out. No, it's there. There's several little holes where the bronchi are leading out to multiple segments. There's another little hole right there. There. There's a little hole right there. Oh, bear with me. A little hole right there. One segment. There's another segment. There's another bronchi. There's another bronchi. There's one right there. There's one right there. Which I can follow back. And I can feel cartilage right in here, coming out to this little area. And you can feel all the cartilage still in there. You can't see it really well, but right there is another one. There. You can feel, you can see it actually coming out to that area. Coming out, moving out through respiratory bronchioles. You can see that it actually forks off there too. Because there's no cartilage in there anymore, which says that you're in a respiratory bronchiole. Yeah, coming right through there. There's another one. If I stick my probe in here, you can see they actually get larger as I moved out here. So I'm going to stick my probe in there. And I'm following it all the way down. All the way into here. This right here, this lining that you can feel, that's the visceral flora. You can see it actually almost comes off. I think that's it. Wow, I don't think I've ever seen it before or paid attention long enough to see it. But I thought, yeah, it has to be. Absolutely. That comes all the way out. No. Yeah, it's very, very marshmallowy. Derek, I don't know what else I can show you. So is this a good time we can sign off?
Yeah, absolutely. Sorry, I was just here. I
worry.
thought that you wanted to keep going kind of thing. So I was just here
No,
for it.
don't worry. Don't worry, I was just gonna keep going, but I'll see you later, okay?
All right. Sounds good. See you next week.
See you not next week, the
Oh,
following
2
week.
weeks. Okay.
All
All right.
right.
Sounds good. See you then. Have a good
See you
holiday.
then. You too. Okay. Don't. I was. Ah.